Okay. I'm Judith Shapiro, London School of Economics, and also an RLMS user. And we have a wonderful session concentrating not only on health, but very heavily on inequality as well. So it should really fit together. And I hope we'll have a great discussion of the relationship between the papers after we've had each and the discussion. Zlata Dorofeeva will first introduce the technicalities. Some of you may have already heard them, but it's good if it's repeated so that we have everything run as smoothly as it has so far. So I'd really like to congratulate the organizers, Zlata and Alina among them, for doing such a terrific job in very difficult circumstances. Okay, so Zlata, the floor is yours. Okay, well, the first paper, let me just introduce you. It's just, and not that I have to take a long time, but we have Alina, you're going to do the presentation. Alina Khabibullina, or you're going to share it. But anyway, the co-authors are here, Ekaterina, Aleksandrova, and Andrey, Aistov, and so it's yours, Alina. And
yeah, thank you very much.
People as well that it's supposed to be 15 minutes and we should try to keep to that. So I can warn you if you'd like, if you're getting close to the time. Okay.
Thank you. I will try. Good afternoon. Today we will present some preliminary results about socioeconomic-related health inequality in Russia. And I want to start with some kind of definitions because you know that individuals from different backgrounds and social groups enjoy different levels of health. And health status can vary greatly among individuals, even within their most developed countries. So health disparities may be an obvious point. Yeah, and some differences in health status exist due to chance or due to genetic reasons. And because of this, health status of different people will be always different. But beside these, let's say, random differences, people's health has systematically different outcomes and for groups that share the common characteristics. And when these systematic differences restrict the ability of one individual to maintain his own health, if we compare with other individuals, we will talk about the health inequality. So two main things that we will talk about: systematic differences, and we will talk that these inequities are socially produced, and we hope that we can modify them. And there exists evidence that inequalities in health indicators persist through time and across societies, and differences in health status and its determinants can be experienced by people grouped by a range of different and complex factors. And one more, that there is well-established relationship between the socioeconomic conditions and between health status. And I think that we can take a look at these relationships through the scheme. So we see that the socioeconomic and political context, such as labor markets, such as education system, and some other political institutions, lead to a set of socioeconomic positions in which the population is stratified in accordance to their, for example, education or occupation or some other factors. And health inequality arises from these socioeconomic positions through the intermediate determinants of health, such as material circumstances, such as behavioral or biological factors, and such as psychosocial factors, for example, stress or social support, and so on. And of course, we see that the healthcare system has an important role in this scheme. And what do we know about socio-economic-related health inequalities? We know that standards of living and income distributions have taken center stage in the discussion in foreign studies, and most studies on Russian data explore health disparities in terms of mortality, morbidity, or life expectancy. And there is not so many evidence about health inequality itself when we use some other health indicators, for example, such as self-assessed health or some other objective health indicators. But one may observe a negative relationship between income inequality and self-assessed health, and we know that bad health is more concentrated among the poor Russians. And few words about the Russian context. Russian income inequality is characterized by the equalization of incomes in the middle class of society and simultaneously by the growing gap between the top and the rest of the population. And also Russia has experienced the rise of life expectancy at birth and decreasing in life mortality before the COVID pandemic. And these trends accompanied by an increase in morbidity rates. Also, despite the economic stagnation, the health care of the Russian Federation has been in a state of permanent reforms for the last decades. Since the beginning of 2006, the national priority project health began, then the healthcare, the same national projects and healthcare national project is still keep going. And the healthcare development was designated as one of the main direction of the country's socioeconomic goals. So research, our objectives in this research, we want to depict the overall picture of socioeconomic-related health inequality in modern Russia. We want to examine changes in this inequality, and we want to try to explore the potential causes of this inequality. So traditionally in health economics, for these purposes, we use concentration curves and concentration indices. The logic behind these measurements are almost the same as in Gini coefficient or Lorentz curve, but these measurements are bivariant measurements. And here you can see the example of this concentration curve. So we use cumulative percentage of the health variable, again, the cumulative percentage of the population ranked by their income, for example, as in our case. And we can check if this curve lies above the equality line or below the equality line. And from the concentration curves, we can derive concentration index, and it's better to understand this measure as the covariance between the health and between the income ranked. What else? About our data. We use 15 waves, and we include in our sample people's 18 years old or older, and we construct several variables for health and healthcare, a kind of healthcare access. We use self-assessed health as binary and continuous variable, and we construct a preventive medical checkup variable, and we construct from several questions about the surgeries, about the hospitalizations, and about the sick leaves, one binary variable. And for socioeconomic status, we use household income divided by the square root of household size. So our sample, we can see in our sample that about 14% of the respondent report bad health, about 16% of the respondent has been hospitalized or has surgeries or sick leaves, and about 19% of our respondents received a medical checkup. If we take a look at the distribution of health indicators, we can see that health status of the respondents in high income groups was better than those in the lower income groups. And the concentration of person in the group with the lowest incomes, so the first quintile, who describe their health as bad, is almost 3 times greater than in the group with the highest income. And the same if we talk about the self-assessed health and new score of self-assessed health. But if we talk about the health access, we can see that in the first period where surgeries and hospitalizations, the likelihood of get these kind of services is almost the same for the whole quintiles. But in time, the likelihood of getting this kind of services changes, and people who have more money, they have more opportunities to get the services. And again, the same about the prevention indicators. And if we talk about the health inequality itself, here you can see concentration curves for several periods for the beginning period and for the last period for each indicator separately. And you can see that all concentration curves that approximate the actual health of the population lie above equality line and indicating that bad health is more concentrated among the people from the low income groups. And we see that for self-assessed health, the concentration curve for the last period lies closer to the equality line, indicating that visually the degree of inequality has become slightly lower over time. And if we talk about health access, the lines lies below the equality line, and the cases of hospitalizations, sick leaves are concentrated among people in high income groups. If we take a look at the concentration indices, we see that the negative value of concentration index means that bad health was concentrated among the low income groups, and healthcare access is more concentrated among the high income groups. But I think that we can, it's more clearly we can see from this slide. So in general, we can make the same conclusions as before. And we can see from the first period to the last period, our concentration index value for indicators of bad self-reported health slightly declined. So we see here that this line become closer to the 0 line. And if we talk about the hospitalizations, if we talk about the prevention, these both indicators behave very similar. But over time, and in general, inequality is increasing for both these indicators. But there has been different periods of slight decline and rise again. So after we assess the health inequality, we want to decompose an inequality measures into a function of its potential causes. And for this purpose, we use recentric influence function regression decomposition method. And here you can see the result of this decomposition. So here you can see the results for each indicator separately, and you can note that this inequality is associated with gender, of course, with age, with some socioeconomic base indicators such as education, employment status, regional, where the respondent is living, and so on. But I think that it's more convenient to summarize this information from this table on the last slide. So, conclusion, we can say that bad health is more concentrated among low-income groups, which is consistent with many other studies in developed and developing countries. Also, we can see that the values of concentration index for self-assessed health were decreasing until 2010, but have remained relatively stable after this period. And the inequality in access to medical services remained relatively low until this period, but began to grow after this period. Maybe this because of some optimization process in healthcare. And the increase in health inequality may be explained by the age, gender, income, own housing, disability group, and living in the city. And this also consists with other studies. But we noticed that living in Moscow and St. Petersburg reduces inequality in health, and this effect exceeds the effect of living in urban areas, for example. And proper education, I mean, if we compare with the primary education, so tertiary and secondary education, or living with a partner or in a large family, the presence of savings help to reduce inequality in self-assessed health. And the effect of socioeconomic factors on health inequality is stronger among respondents without bad habits. So people who are smoking or drinking tend to reduce inequality, but this doesn't mean that people should start to smoke or drink to decrease this inequality. Of course not. and income, average educational attainment, large family living, and urban areas reduce inequalities in access to health services. So I think this is all for now. Thank you for your attention.
Okay, that was perfect timing. Questions and comments? Okay, I see Irina. Irina, you want to?
Yes, thank you so much. Thank you for this very interesting presentation. I have one clarification question and one question. So the clarification one is that, well, I probably was too slow, and I do not understand what is this second measure of self-assessed health. So if you could clarify, that would be great. But before I switch off my mic, so I was thinking about, given that self-assessed health is a noisy measure in the sense that it's really subjective and, well, it's very difficult to compare across people. So that there are definitely, well, types of behavior like smoking and drinking who are just indicators of, well, later consequences. And instead of controlling them to the right, so thinking how they are related to other measures, I was thinking about using them as a measure of inequality in the sense, in terms of the technology of improving your health or deteriorating your health. So I was thinking about a different approach, and I think it would be very interesting to use it. Well, how unequal is the related to socioeconomic status, those bad habits. Thank you.
Okay, thank you very much. Yeah, self-assessed health is a subjective measure of general health, and they have some weaknesses, of course, and we can check a robust with other measures. And because of this, we try to transform this categorical measure in a continuous. We use specific approach. First of all, we regressed this categorical self-assessed health on a set of covariates using an ordered probed model, and then we predict a new health score. And this predicted new health score we rescaled using min-max normalization, a kind of. So this was a kind of experiment, and that was recommended in other surveys. And we tried to check if our results will be the same if we use binary variable or if we use such kind of continuous variables, because these indices, of course, is more convenient for continuous variables, and only because of this. And of course, it will be great to use some objective measures. Yeah, some, for example, BMI maybe also, or some drinking or alcoholic. We will check these results. Thank you very much.
Other questions and comments? I know we have someone present who gave a paper which is related and might want to comment on his findings, Silas, and compared to Alina's, because one of the great things about this conference is it allows us to meet other people who are working in very close areas, just as Irina's contribution did. So anybody else?
Judith, can I please give a comment?
Yes,
Since you
yes.
mentioned this paper is kind of related to what I did, and it's very interesting. Thanks, Alina. Sorry, I could not turn on my video because there is a technical issue with my internet right now. First, I think the self-assessed health, is true that there is a problem with the measurement, because in the literature it has a bit of a measurement error, but the way in which you do the predicted one, I think that's what I use for the paper I presented this morning, where I try to see how health status affect the utility function of the individual. And one way you can also look at it is there is a paper that tries to link self-assessed health with objective measures of health, and mainly chronic health conditions. So one way to see how this is done is to just run a regression of self-assessed health on dummies of diagnosed chronic health measures, just these two. And here the idea is to see how fluctuations in diagnosed health status predicts self-assessed health. So in this way, you are not sort of putting much noise from other socioeconomic or demographic characteristics. It's just objective health and self-assessed health. And in the literature, this has been shown to be like a very good measure to sort of correct the biasness or the measurement error in the subjective self-assessment. So maybe you can also look at that and see if the results is robust to this new measure of health. Thanks.
Yeah, thank you very much. And if you have such kind of paper and you could share with me, I will be grateful for you.
I'm sure we can discuss this later between us, and then you can send an
Thank you very
email,
much.
and then we can discuss that.
Mm-hmm.
Other questions and comments? I don't see one. I have a quick one. I just want to know if I have it right, that you're finding that smoking and drinking reduces inequality. What that means is that correct? That in fact, in Russia, at least in the RLMS, that the upper income groups are smoking and drinking more. Can I conclude that, or we don't know what the dynamic is? Because it's not a finding you find in other countries. With smoking, for example, the UK and the Western European ones, the lowest income group sometimes smokes less because they're just too poor to afford it. But that's not the case for the other 4 quintiles. So I wondered which is driving your result, because it's an interesting one and a striking one.
Yeah, but I think when I saw this result, I think in the way that people from low quintile income groups have a similar bad health. And because of this, maybe we talk about the socioeconomic-related inequality. Maybe because of this, they don't stop, for example, to smoke or to drink. They have enough money, and the elasticity of tobacco consumption in Russia is inelastic, I think, because of this, maybe.
Okay, I think that's another area which some people are taking up in other parts of the conference that there could be some good interaction on. Other questions and comments now? We can also discuss the totality of it if we have enough time at the end. So shall we thank the Alina and the first paper and move on to the second, okay? Thanks very much for a very thorough presentation and discussion. Okay, so we have the next one. Who's presenting there? Yeah. Is it going to be Andrey or Evgeniy?
Yeah, good afternoon.
Both of you are, okay, so we have it, Andrey Aistov and Evgeniy Zazdravnykh, and take it away, Evgeniy. Okay.
Oh, well, so, yeah, good afternoon. So my name is Evgeniy, and my co-author is Andrey Aistov. So first, thank you organizers for the great opportunity to share our results with the audience. And today we would like to talk about our recent empirical research project, which is about income elasticity of healthcare spending on self and professional treatment. Well, this topic itself is a very old topic in the field of health economics, and different authors try to understand whether healthcare is a luxury or necessary good at national or individual levels. Well, and recent studies on income elasticity of health spending usually discussed as total health spending or expenditure on different kinds of care, for example, GPs, inpatient, outpatient care. For sure, they cover developed and developing countries, and as a rule finds that health is necessary good at the individual level, and it could be even luxury good at the individual level if we examine cases of developing countries. But we suppose that authors could miss one interesting phenomenon. This phenomenon is a self-treatment, which is a very popular in developing countries. Hence, in reality, persons with any illness make a decision whether rely on self-treatment or visit a doctor, because each decision has own pros and cons. And if they think that visiting a doctor is sufficiently affordable for them, they could visit it, pay for prescribed medications, or probably for physician consultation. But if they feel that professional care is unaffordable, as it is a luxury good, they could rely on self-treatment. I asked we could observe a selection of persons into two groups. First group is those who prefer self-treatment because of it is cheap, it is the access to medications, pharmacies could be relatively easy and fast. And the second group, those who could prefer professional care. And because of the selection problem, studies could underestimate the real affordability of professional care, well, which could lead to wrong policy implications. And in our project, we try to address this problem and to estimate income elasticities of healthcare spending on self-treatment, professional care, and compare them to understand better why self-treatment is a popular behavior among developing countries. Well, pre-research shows that the self-treatment could be an inferior good. For example, there is a model Chang-Contributed which argues that self-treatment must be an inferior good, meaning that spending on self-treatment is decreasing with the income increase. And the professional care must be a normal good, meaning that spending on the healthcare must increase with the income increase. These authors try to empirically examine the model and found that on average, self-treatment is necessary normally good, but it could be an inferior good among high-income group of population. And the subsequent research done by Pogan and co-authors in 2006 find a similar pattern. So they find that self-treatment on average is a normal, necessary good. But both Chang-Contributed and Pagan and co-authors don't compare income elasticities of self-treatment with income elasticities of professional treatment. Well, to our minds, there are two studies close to our topic. So the first study discusses case of Zambia, and the author tries to find out whether self-treatment is a necessary good and professional care is a luxury good. She finds that both options are necessary normal goods on average, but professional care is close to the luxury level, while self-treatment is definitely so a normal necessary good. Well, but so the drawback, we suppose, of this research that the author doesn't discuss the selection problem, selection into self-treatment and professional treatment group, while recent studies examining a choice between self-treatment and professional treatment often stress that persons with low income, low education, and without severe health problems prefer self-treatment instead of professional treatment. Well, another study is done by Ross and Hodgkins in the same year, and the use case of Nepal. And they find that on average, self-treatment is inelastic on income, but professional treatment is in public healthcare institution, private healthcare institutions have positive income elasticities. And at the same time, these income elasticities are below the unity level, meaning that health, so the official health care is a necessary good. But they also don't discuss a selection problem. Moreover, these two studies examine cases of low-income countries with underfunded public health care system, and probably with a small medications market. Well, and because of this, Russia could be an interesting case, because first in Russia there is a mandatory health insurance system which covers costs of treatment in mostly public healthcare institutions, and sometimes it could cover costs of treatment in even private organizations. But at the same time, it doesn't cover spending on medications for the vast majority of populations. There are small exemptions when mandatory health insurance reimburse expenditure on medications. So, for example, veterans and so some retired persons could take these exemptions. But so usually people with severe health problems or even severe health problems has to spend their own money to buy medications. Well, and this probably is the first channel why we need to spend money on health in Russia. So another channel is about healthcare services itself. Well, when a person visits a public healthcare institution, she or he could take a service for free. But if the patient wants to get a better quality of service, or maybe this patient doesn't wait a lot, he can pay for such a service. He can pay for the service which is offered for free. Well, this payment could be official, this payment could be official, and we see that especially in official payments are fairly popular among Russian patients. Thus, when a person prefers to visit a physician, he needs or he can to pay for the physician consultation, and usually he has to pay to purchase different medications. Well, another option is to rely on self-treatment. This option is available for the majority of Russian population because it's fairly easy to buy different medications without visiting physician office. And moreover, so studies stress that we can buy prescribed medications without permission from a doctor. Well, and probably because of this, self-treatment is fairly popular among Russians. Recent studies show that at least, for example, 73% of adult population rely on self-medication with antibiotics. Another studies show similar rates, so meaning that at least half of persons with health problems in Russia prefer self-treatment instead of professional care. Probably Russians are sufficiently healthy to rely on self-treatment, and probably they don't want to spend time visiting doctor because they need to wait in a queue. It's probably they have to buy expensive medications, and because of this, they rely on self-treatment. Thus, in Russia, a person has two options. So the first option, to visit a pharmacy and purchase medications after a short consultation with a pharmacist, or to visit a doctor, spending time, probably money, well, and again visit a pharmacist to buy prescribed or recommended medications. Well, and moreover, and for sure, so Russia, in contrast to Nepal and Zambia, it is a middle-income country with so large network of public healthcare institutions, which makes health services available for everyone as a part of Soviet heritage. In order to ask our research question, we try to employ the indigenous switching regression model. So the idea of this method is so simple. First, we estimate the binary dependent variable equation. So this is equation. Its dependent variables means whether a person relies on self-treatment or professional treatment. In our research, we consider persons with health problems only. Well, and so this person has two options: self-treatment or professional care. And next, once we estimate the selection equation, we estimate two main equations. The first equation explains the variation of spending on medications when a person relies on self-treatment. The second equation explains the variation of spending on either medications or physician consultations or both when a person relies on professional care. Well, and for sure we can compare the estimated coefficients which reflect income elasticities. Well, in our research, for sure, we use Russia longitudinal monitoring survey for the period from 2009 to 2017 years, and our sample covers adult population where the minimum age is 17 years and there is no limit for the maximum age. And we employ three possible dependent variables reflecting three possible scenarios. First scenario, imagine a person who has an illness and makes a decision between self-treatment or professional care. If this person prefers professional care, he can pay for a physician consultation, but he doesn't pay for medications. He doesn't purchase medications. Well, for example, so it could be medical checkup. Another scenario is an opposite case. So again, person makes a choice between self-treatment and professional care, but now this person doesn't pay for physician consultation and purchases medications. It could be a typical case for many Russians when we visit a public healthcare institution, take and get there some recommendations to take drugs, medications, and do something else. Well, and for sure we consume this, we spend money on medications from our own income. And the last scenario combines two previous scenarios. So it means that when a person visits a doctor, he has to pay for medications and physician consultation. Well, we estimate our econometric equation 3 times and get 3 models. Our indicator variable is the same among all models, meaning that, and it takes 1 when a person relies on self-treatment. Our variable of interest is a household expenditure per capita, we use the expenditure approach to measure personal income, following recommendations of Deaton published in the subsequent years. And for sure, we use large sets of control variables. We control for household size, personal socio-demographic characteristics, and personal health variables, including self-assessed health, the existence of stroke, high blood pressure, and other characteristics. In order to explain the variation of our selection variables, in addition to control variables, we use information about smoking, sport activities, life satisfactions, and occupations. The choice of this selection variable is made on the basis of previous research on self-treatment. Well, and what we have first, we tried to conduct a simple statistical analysis, and it shows slightly different patterns in each scenario. Well, first, imagine a person who pays for physician consultation and doesn't pay for medications. We see that in this case, persons with large average income, large average household income, prefer professional treatment. And for sure, these persons spend substantially more on health. Well, we see that these differences are fairly large and statistically significant. But if we look at this, the other cases, we see that the difference in household expenditure isn't statistically significant, so meaning that average household incomes are fairly close to each other, but spending on health are different, and this difference is also fairly large. So, for example, in the second case, we see that spending on health are twofold bigger than that of the first case. And the same could be said in principle about the third case, when a patient has to pay for physician consultation and medications. For sure, this analysis cannot be specific because we don't take into account effects of control variables. And the second slide shows the summary of our regression models. Unfortunately, I can't show the whole models because they are very long. And because of this, we would like to focus on our principal results. Three panels reflects three estimated models, and this row shows our estimates for our for our explanatory variables. Well, the first case, patient pays for physician consultation and doesn't pay for medication. We see that both self-treatment and professional treatment are so necessary, normally good. And at the same time, we see that on average, persons with lower income are less likely to rely on self-medication, and our test for the difference in coefficients shows that these coefficients are close to each other. This difference isn't statistically significant. Well, it shows that probably there is no difference in self-treatment and professional treatment when there is no need to purchase medications for a person. But when there is a need to purchase some medications, we observe certain differences. The second case means that a person has to pay for medication but doesn't pay for a physician consultation. And here we see that coefficients are different, and this difference is statistically significant. And the same can be said about the last case, where we also see that these differences are statistically so significant. Well, what we see that indeed both routes show so different affordabilities of different treatment options. So, and probably when we need to purchase medications, we feel that this option could be less affordable for us. Well, and so to sum up, we see that the need to purchase medications make these options different for patients, and well, probably we observe this pattern because mandatory health insurance doesn't reimburse medications or related materials. I think that's all. So thank you for your attention and for the coming questions.
Okay, thank you very much. Questions, comments? Okay. Do I see any hands? You can just put them up on the screen, or you can click on participants and put up your hand.
Yeah.
Actually, I don't see the place to put up the hands. I don't see the place to put up the hands, Lana.
Irina Denisova.
Okay, so go ahead.
Thank you so much. Thank you very much. Generally I like the direction you are looking at. I mean, the area you're looking at, because it's really interesting. Well, how people, what makes people to decide that they don't need professional care and rather use self-treatment, and there are things to investigate in this area, in particular in Russia. What is questionable for me, well, probably I didn't get the whole idea at the moment, because the exposition is anyway very brief. How can you have the self-treatment in your cases A and C, where you have to pay for physician consultation? If it's self-treatment, then you don't consult physician. Well, you use medication, so I can't get this. So if you could explain me more about this idea. And the second thing is that you started with the literature related to well, very developing countries, and then you switched to the Russian case, saying that that there is this access through the public insurance system to at least majority of healthcare services. And I would suggest that well, while you introduce this literature, just from the very beginning mention that this is a related literature, but definitely Russia is not in this well, particular group, so that well, you don't have I don't know, I was, if that was a different kind of seminar, I would stop you immediately asking how come. Well, you have an option to have access. There could be some regional problems, regional differences in waiting lines and all this stuff, but definitely we're not in the situation where other developing countries are. So I like the idea, but I do not understand the methodology in the respect that you define well, those two groups. I understand the group B, but I don't understand group A and C. And on top of this, I would add that this is a really interesting example, because during this COVID era, I have my classmate, she's living in the Netherlands now. And I was, well, the strategy, she got COVID, and she was trying to, she was consulting her a family doctor who prescribed nothing. And my understanding was that at least in your age group, at least Trombas or something like that was useful. She couldn't get access to this. And in this sense, she has to stick to the technology which is available in Netherlands, so that either you have some prescription of medicine from the doctor, or you don't get anything. Here, we are, in some sense, have more choices. In some sense, because we have we can use different technology of I don't know, using our internet knowledge and buying some medicine which is available in Russia for sale, for free sale, and not available in other countries. And that's an interesting issue. Well, how choices are made under this different situation, and what's the difference in results in the end. Well, if you have this availability of this option, or you don't have this availability, as say in Europe. Thank you.
Well, yeah. So thank you very much for your comments. Well, for sure, we need to. And we will try to justify and explain reason to use panel A and panel C. Well, I think that, yeah, so that's an interesting point when there is no need to pay for medications. So probably it's not a usual case, because when we don't need to buy medications from by ourselves, it could be a severe illness when we need to take treatment in the hospital.
No, I was asking about self-treatment and the case where patient pays for physician consultation. Well, this is in case A and C, and well, what do you mean by this? If it's self-treatment, then there is no physician consultation.
It means that two cases. Self-treatment. So when person purchases medications, and the second case, professional treatment, person pays for physician consultation and doesn't pay for medication. So we exclude spending for medications to trying to separate effects of payments for physicians and medications to understand which effect plays a greater role in making a decision between self-treatment professional.
But then, well, what is your dependent variable in panel A?
Panel A, the same. So spending on health. So in self-treatment, it is spending on medication. In case of professional treatment, it is spending on physician consultation.
Okay, well, I will need to read your paper.
Yes. Okay. Other comments and questions on either this or similar issues that have been raised? Because we'll move on. Marina.
Могу ли я задать вопрос по-русски? Могу ли я задать вопрос? Евгений, спасибо. Вы слышите меня, Евгений?
Конечно, конечно.
Евгений, спасибо большое. Скажите, пожалуйста, возможно, это прозвучало, вы говорили про степень тяжести заболевания. Ну, это как бы понятно, что с самолечением люди в большей степени лечат какие-то легкие простуды там, и обращаются к врачу в более тяжелых случаях. Нет ли возможности как-то вот ограничить выборку только теми, кто болел легко, и только теми, кто болел тяжело? Таким образом, сравнивая сравнимое, вот как-то, может быть, что-то есть возможность в эту сторону посмотреть?
Да, спасибо за комментарии. Мы действительно долго думали об этой. Эта проблема существует в нашей работе, мы долго об этом думали. Но, к сожалению, у нас такой возможности нет, потому что база данных, которой мы располагаем, она не содержит информацию о том, чем респондент болел, или некую самооценку, насколько серьезное было заболевание в последние 30 дней. Поэтому все, что мы можем сделать, это включить переменные как self-assessed health, хронические заболевания, ну, те, которыми располагает RLMS. Спасибо.
Marina, еще вопрос или выдавали?
Спасибо, спасибо.
Okay, so sorry?
We have a question from Yana.
Yes.
Yes, Yana?
Яна, yes.
Да, спасибо. У меня на самом деле не вопрос, а реакция на то, что нет информации о том, чем человек болел за 30 дней. На самом деле есть текстовый вопрос такой. Я не помню, есть ли он в последние годы, но за довольно большое количество лет он точно был. Поэтому можно это поднять и посмотреть. Более того, одна студентка у меня делала типологию вот этих самых заболеваний на более серьезные, менее серьезные, поэтому, по крайней мере, можно запросить, возможно, этого вопроса просто нет в общих данных, но если вы нам напишите, мы посмотрим обязательно.
Да, огромное спасибо.
Okay. Sure. I see no other hands anymore. I just wanted to note one thing, which is a separate question. It has to do with antibiotics. You have mentioned that in your slides about the St. Petersburg finding. And there is quite a literature right now on Russian over-the-counter antibiotics, and the laws are changing, as people know. So hopefully some of this will show up in some of the data collected for this year and next year that might see a change. And it's there is international attention on it because there is concern about the fact. I mean, I know because I cheat. When I go to Russia, the first thing I do is go to the pharmacy and ask for things I can't get at home, and I can still get Romantadine, but I can't get antibiotics. And the concern about Russia as a distributor of them has caused interesting international attention. So I hope the RLMS will have something to contribute on that. And it's quite useful, and this paper will be useful for that. Okay, more? Right, we have the last paper then. Marina Kartseva and Polina Kuznetsova. And I don't know if you're presenting in Russian. The paper, which is very full and complete, is in Russian. And so you may wish to do that, in which case, if anybody needs it, interpretation can be had. Okay. It looks like it's in English.
Микрофон, Мариш. Мариша, микрофон.
You are on mute, which is the Oxford English phrase of the year.
Спасибо, спасибо. Моя презентация сегодня на русском, и я попробую справиться с техническими трудностями. Видно мои слайды? В порядке?
Слайды видны.
Да. Добрый день, уважаемые коллеги. Я хочу поблагодарить организаторов за приглашение на конференцию. Я безумно рада сегодня вас всех видеть, пусть и виртуально. И сегодня я хочу представить основные, первые, они же основные результаты работы, выполненной совместно с Полиной Кузнецовой. Она сегодня тоже здесь присутствует. И наша работа в некоторой степени, так получилось, в некоторой степени продолжает первую из представленных сегодня работ, и она посвящена анализу справедливости неравенства в здоровье в России. Ну, не вызывает никаких сомнений то, что здоровье – это один из ключевых факторов благополучия человека. Здоровье существенно влияет практически на все социальные и экономические аспекты жизни человека. Это и образование, и занятость, и какая-то общественная деятельность, и рождение, воспитание детей. Таким образом, неравенство в здоровье, которое, ну, само по себе, да, неравенство в здоровье, оно может вызывать неравенство, быть причиной неравенства в других показателях и способствовать воспроизводству неравенства во времени. Поэтому снижение неравенства в здоровье является важнейшей задачей развития как на мировом, так и на национальном уровне. И в настоящее время существует понимание того, что вот неравенство в здоровье, оно вызвано не только текущими социально-экономическими характеристиками человека, но и также различиями условий, в которых человек родился и жил, то есть теми факторами, на которые человек не имеет никакого влияния. В современной философской литературе факторы, на которые человек не имеет влияния, экзогенные для него факторы, если неравенство достижений вызвано вот этими экзогенными факторами, то такое неравенство достижений в современной литературе рассматривается как несправедливое. Эти факторы, обстоятельства, экзогенные для человека факторы – это пол, место рождения, раса, национальность, различные родительские характеристики, здоровье, образование, доход, любые. И вот если эти экзогенные факторы во многом определяют неравенство достижений индивидов, то тогда имеет место высокое неравенство возможностей. То есть именно в этом состоит концепция неравенства возможностей. И неравенство возможностей в современном либеральном обществе рассматривается как совершенно неприемлемое. Считается, что усилия общества и государства должны быть направлены на снижение неравенства возможностей. Если же неравенство достижений вызвано неравенством прилагаемых усилий, то есть теми факторами, на которые человек может влиять, то такое неравенство, оно обществом оправдано, является социально приемлемым и даже в некотором смысле поощряется. Таким образом, понимание того, какая часть существующего неравенства в здоровье объясняется обстоятельствами, то есть теми факторами, на которые человек не может влиять, другими словами, понимание того, насколько велико неравенство возможностей здоровья, оно может дать политикам важную информацию о механизмах формирования существующего неравенства, а также о том, насколько в обществе существует запрос на компенсацию этого неравенства. В зарубежной литературе существует целый поток исследований, который количественно анализирует неравенство возможностей в здоровье. Так, например, в европейских странах 50% неравенства в здоровье объясняется, собственно, обстоятельствами. То есть 57% неравенства в здоровье может быть рассматриваться как несправедливое. Наиболее высокие показатели неравенства возможностей в здоровье отмечаются в Чехии, Испании и Греции, а наоборот, самые низкие показатели неравенства возможностей в здоровье в Бельгии, Голландии и Швейцарии. В России неравенство в здоровье – это очень актуальная проблема. Существует значительное неравенство в здоровье между различными демографическими и социально-экономическими группами, как было показано сегодня в первой презентации. Также существует отдельное свидетельство о влиянии характеристик родительской семьи на здоровье взрослого населения. Насколько нам известно, до текущего момента количественных оценок неравенства возможностей в здоровье в России получено не было, и основная цель нашей работы, собственно, эти оценки получить и оценить степень справедливости и несправедливости неравенства в здоровье в России. В качестве эмпирической основы исследования мы используем данные РЛМС за 2018 год, 26-й раунд. Данные содержат подробную информацию о здоровье индивидов, о самосохранительном поведении индивидов, об их социально-экономическом статусе. Почему мы выбираем именно 26-й раунд? Ответ тут очень простой. В 26-м раунде содержится информация о родителях респондента, в частности, об их образовании. Мы фокусируем наше внимание на респондентах в возрасте от 25 до 74 лет, и общий объем выборки составляет у нас порядка 8 тысяч наблюдений. Здоровье в работе характеризуется самооценкой здоровья, которая в РЛМС оценивается по 5-бальной шкале от очень плохого до очень хорошего. Сегодня достоинства этого индикатора, достоинства и недостатки обсуждались. В целом, безусловно, я согласна, что самооценка здоровья не является объективным с медицинской точки зрения показателем здоровья, однако в литературе она считается важным фактором заболеваемости и смертности, и данный индикатор широко используется в литературе, посвященной изучению неравенства возможностей здоровья, что отчасти дает нам возможность проведения международных сопоставлений. В нашей выборке треть индивидов, они имеют хорошее или очень хорошее здоровье, чуть больше половины оценивают свое здоровье как среднее, и только каждый 10-й сообщил о том, что его здоровье плохое или очень плохое. В качестве индикаторов обстоятельств, то есть тех факторов, которые не зависят от человека, мы рассматриваем характеристики места рождения респондента. 3 переменных: родился в России, не в России, родился в том же самом месте, где живет сейчас, или в другом, и даме переменную, характеризующую тип поселения: родился в городе и родился в сельской местности. Важнейшим обстоятельством родительской семьи является образование родителей, и в качестве характеристики образования родителей мы используем максимум из количества лет обучения отца и матери. Усилия в работе характеризуются 3 показателями: это собственное образование, а именно наличие высшего образования, статус курильщика, курит человек или не курит, и физическая активность человека. Мы считаем, что человек был физически активен, или человек физически активен, если он выполняет хотя бы легкие упражнения, хотя бы иногда. Легкий критерий. На слайде представлены описательные статистики, я думаю, мы не будем на них останавливаться и перейдем к обсуждению методологии. На первом этапе исследования был проведен эконометрический анализ зависимости здоровья от показателей обстоятельств и усилий. Оценка уравнения здоровья. Оценка уравнения здоровья в данном случае не вполне простая эмпирическая задача, и в основном это связано с тем, что обстоятельства имеют не только прямое влияние на здоровье человека, но и опосредованное влияние через усилия. То есть обстоятельства, например, определяют вероятность курения, а курение, в свою очередь, влияет на здоровье. И что бы нам хотелось, это получить совокупный эффект, оценить совокупный эффект, прямой и непрямой, на здоровье. В случае линейной модели с этим проблем никаких не было бы, однако в нашем случае индикатор здоровья дискретный, ранговый, что приводит к нелинейности модели, и в данном случае необходимо применение специальной методики, и мы следуем подходу, предложенному в работе Трануа и коллег в 2010 году. Согласно этому подходу, на первом этапе проводится регрессионное оценивание уравнений зависимости индикаторов усилий от индикаторов обстоятельств при помощи логит-модели, бинарной логит-модели. На втором этапе остатки регрессии усилий добавляются в качестве зависимых переменных. Мы можем видеть это вот здесь в последнем уравнении. Остатки добавляются в уравнении здоровья в качестве зависимых переменных. Эти остатки и есть очищенные от влияния обстоятельств усилия. Дальше уравнение здоровья оценивается с помощью порядковой логик-модели. На втором этапе работы мы, собственно, оцениваем неравенство возможностей здоровья. И здесь в основе примененной методологии лежит непараметрический подход к оценке неравенства возможностей в достижениях, предложенный в статье Кейки и Пираджина в 2010 году. И идея этого подхода состоит в сравнении наблюдаемого распределения здоровья в данном случае с гипотетическим распределением здоровья, каким оно могло бы быть при равенстве обстоятельств. Однако прямое применение данной методики требует непрерывность индикатора достижений, непрерывность индикатора здоровья. Опять мы сталкиваемся с той же проблемой. Чтобы ее преодолеть, мы используем адаптацию непараметрического подхода, предложенную в статье Лазар. Согласно этой методике, на первом этапе на основе оценок, полученных при моделировании уравнения здоровья, для каждого индивида предсказывается латентная непрерывная переменная здоровья. На втором этапе, опять же, на базе оценок, полученных при моделировании уравнения здоровья, мы строим агрегированные переменные усилий и агрегированную переменную стартовых возможностей. На третьем этапе мы разделяем нашу выборку на 5 категорий в зависимости от уровня усилий, на 5 категорий в зависимости от уровня обстоятельств. И строим гипотетическое распределение здоровья. И вот, сравнивая эти распределения, мы оцениваем неравенство возможностей здоровья. Это показатель тета, который определяет долю неравенства в здоровье, которая является несправедливой. Значит, еще хочу заметить, что в качестве измерителя неравенства мы используем среднелогарифмическое отклонение. Теперь давайте перейдем к обсуждению результатов. Что у нас получилось? Ну, во-первых, и это видно сразу, обстоятельства являются важнейшими факторами состояния здоровья человека. Регрессионный анализ показал, что если человек родился не в России или он родился в другом месте, не в том, в котором он живет, то самооценка его здоровья ниже. Рожденные в городах также склонны к более низкой оценке своего здоровья. Возможно, мы предполагаем это, потому что они имеют более критический взгляд на свое здоровье. Достаточно интересные результаты были получены в части влияния образования родителей на здоровье взрослого населения. Согласно нашим расчетам, образование родителей не имеет прямого эффекта, не имеет значимого прямого эффекта на здоровье потомков, но оно играет важнейшую роль в формировании их образа жизни и во многом определяет уровень усилий образования, статус курильщика, физическую активность. То есть мы подтвердили наличие значимого прямого эффекта, но наличие значимого прямого эффекта не подтвердилось. И, что хорошо, все 3 рассмотренных типа усилий, они позитивно ассоциированы с состоянием здоровья. Ну и теперь, собственно, самое важное, насколько справедливо неравенство здоровья в России. Согласно нашему исследованию, 72-74% неравенства здоровья объясняется неравенством обстоятельств. Для женщин неравенство возможностей здоровья несколько выше, чем для мужчин. То есть 3/4 неравенства в здоровье в России объясняется теми факторами, на которые человек не может влиять. 3/4 неравенства в здоровье в России являются несправедливым. Что, мы можем говорить о том, что неравенство возможностей в России довольно велико. Ситуация в России сравнима с ситуацией в тех странах Европы, о которых я уже говорила, это Чехия, Испания и Греция, и с отдельными странами Латинской Америки. Что это значит? Это значит, что меры, направленные на компенсацию текущего наблюдаемого межгруппового неравенства в здоровье, они могут иметь ограниченную эффективность. И при разработке мер снижения неравенства в здоровье следует существенное внимание уделять тем мерам, которые могли бы компенсировать неравенство обстоятельств в детстве. На этом, наверное, сегодня все. Спасибо большое за внимание. Для нас с Полиной это новая тема. Это первая наша работа в этой области, и мы будем очень рады, если у вас будут какие-либо комментарии, замечания, вопросы, предложения. Большое спасибо.
Спасибо большое. We have comments. I already see Jana's hand. Others? Okay, Jana.
Да, я могу комментировать. Спасибо. Да, во-первых, спасибо большое за доклад. Я тоже давно интересуюсь этой темой. Еще в 2007 году на данных RLMS я смотрела, как влияют, я их тогда называла позитивные и негативные инвестиции в здоровье, на то, как человек приобретает хронические болезни. Ну, с тех пор, не знаю, ситуация, может быть, чуть-чуть улучшилась со здоровьем населения, со смертностью, но все равно, безусловно, вот каждая такая работа, мне кажется, что для России это очень важно. Мне также очень понравилось, что вы используете такой, нетрадиционный метод, да, разделения на прямые и косвенные, да, факторы, пытаетесь оценить условия и то, что человек сам делает. Мне кажется, что это тоже очень продуктивно. Но мне кажется, что, возможно, имеет смысл подумать о каких-то еще дополнительных факторах, потому что, безусловно, курение, занятие спортом, да, тут, в общем, трудно поспорить, хотя вот по моим данным получалось, что на некоторые хронические болезни спорт влияет не очень хорошо. В частности, на болезни, которые связаны с позвоночником, да, вот чрезмерно, когда человек много занимается спортом, это плохо. Но неважно, в данном случае это можно, так сказать, и так оставить, но меня удивило, что совсем нет алкоголя, потому что, конечно, алкоголь для России, по крайней мере, раньше это всегда был очень серьезный фактор и смертности, и плохого здоровья. Сейчас люди, конечно, по данным РЛМС, по крайней мере, и Росстата пьют намного меньше, хотя вот мои путешествия по провинциальной России показывают, что, видимо, не все статистика отражает. Много-много видно людей, которые много пьют. Но, тем не менее, мне кажется, что обязательно нужно учесть алкоголь и, возможно, не линейно. Правда, я бы также подумала, может быть, на вашем месте, чтобы сделать лаги и для алкоголя, и для курения, потому что мы хорошо знаем, что не сразу проявляются последствия для здоровья и алкоголя и курения. Ну и посмотрите также, может быть, какие-то другие факторы, потому что есть интересный вопрос про вредное производство, например, да, тоже очевидно, что это может влиять на здоровье, ну и целый ряд других. А так, мне кажется, очень хорошая перспектива, да, спасибо.
Яна, спасибо большое. Спасибо большое, во-первых, за добрые слова в наш адрес. Это нам очень приятно. Безусловно, мы в основе, и когда начинали наши исследования, ну, первое, что мы читали, это ваши работы по России. Вот. Алкоголь. Это, конечно, была наша первая мысль. Курение, алкоголь, образование, спорт. И даже спорт не так важен, как алкоголь. Но все наши попытки учесть алкоголь, к сожалению, не привели к какому-либо значимому результату. Почему? Потому что, вероятно, вот опросы меряют алкоголь не так хорошо, как нам хотелось бы. И мы пробовали сделать нелинейность тоже в том смысле, сколько человек пьет, что человек пьет, то есть там heavy drink. И получается, что тех, кто в РМЭЗе пьет очень много, их очень мало. Мы не можем как бы базироваться на тех 10 человеках, не можем базировать анализ на тех 10, там, тех 100, которые действительно выпивают там, по бутылке водки в неделю. Вот. То есть получилось, что эта переменная, к сожалению, вот, не работает. Но мы продолжаем работу в эту сторону. Большое спасибо. Влаги, алкоголя и курение – это отличная идея. Вредное производство тоже попробуем, хотя вредное производство – это, безусловно, только для работающих или для тех, кто работал на нем раньше. И не ясно, что будет для неработающих, но мы попробуем. Во всяком случае, эту область тоже интересно посмотреть. Вот, другие факторы, да, мы еще, я как бы забыла сказать, что мы контролировали на демографию, на пол и возраст человека. Ну, это довольно очевидные вещи.
Ну, если позволите, буквально одно вот на ваш ответ. Ну, что касается вредного производства, это очень легко. Либо оно есть для тех, кто работает, либо его нет для тех, кто не работает, и для тех, кто работает не на вредном производстве. Тут как бы мне кажется, тут вообще никаких затруднений нет. Но тоже, возможно, с лагом нужно, да. А что касается алкоголя, то, ну, во-первых, не так уж мало людей пьет достаточно много. Во-вторых, тут, мне кажется, нужно, в общем, больше еще поискать какие-то границы, потому что в любом случае это выглядит очень странно, когда вы вообще алкоголь исключаете. Ну, пусть он там у вас как-то незначим будет или что-то, но во всяком случае, мне кажется, про это нужно подумать. Либо вот я, например, в свое время использовала объемы, квадрат объема, или можно вводить какие-то дамы, там человек не пьет, пьет умеренно или пьет там выше определенного объема. Вот по моему опыту, даже если взять абсолютный алкоголь, ну тоже я там по разным рекомендациям рассчитывала, если мы берем за 30 дней, скажем, 400 грамм абсолютного алкоголя для женщины больше, и 800 грамм для мужчин и больше, это за месяц, то, в принципе, вот такие вещи, их принято называть чрезмерным потреблением, и они, в общем-то, уже сказываются на, ну, в общем, очень многих, имеет очень много последствий. Но в любом случае, если вам будет интересно, мы можем приватно это встретиться или, ну, в переписке обсудить, не обязательно во время конференции и позже.
С удовольствием, Яна. Спасибо большое. Judith, we can't hear you.
You should. Judith, turn on your microphone, please.
Judith, now you are muted.
Yes, I am. Sorry. Okay, sorry. I wanted to know if the exchange between Yana and Marina was included, so I could ask for others, or if you wanted to come back, or it's been extremely interesting for all of us to have to. Others on alcohol. I have a different question, which you only touch on, which has to do with the effects of child health. I think that one of your next steps might be to look over time at the RLMS, because I think myself that there has been a stunning decline in infant mortality, and we haven't really taken that into account. And it's not obvious to me what that does to morbidity, and therefore the influence of child morbidity on adult morbidity, because if lives are saved, the children may be in ill health when they would not have been alive. So seeing the implications for this and for our health services in Russia is very important. And I don't know, I'm not sure why, but I noticed that the Russian experts, you people, are not paying a lot of attention to this stunning fall in infant mortality. I suspect it's because you are aware that it's still a lot higher than it should be. But I'm curious to know how you feel about the impact of that on adult health. That is, what's happened to child health. And we're talking about people to the age of 14. If no one has a response on that, I don't want to linger on it. Okay. Other questions and comments? If there are no more comments on this paper, can I suggest that people may have other points to contribute on health inequality and health spending in general that they might want to offer? And that includes the people like Marina, who have just given papers, but might want to comment on the work of others, because we have a chance for the panel to talk that we're not going to have again soon. Is there anybody else? Oh, okay. Going once, twice, three times. I think that's it. We have a lunch break now, essentially. Although you can ask to be in breakout rooms and speak to each other. I thought it was a wonderful session of excellent people and other experts coming in, and it's what this conference is all about. So I wanted to thank the organizers again and thank the paper givers and the audience. Okay, so that's it for now. Irina, you have your hand up. No?
No, that was applause.
Saying goodbye. You're just saying thank you. Okay, other people want to say thank you to the paper givers. Okay, okay, that's it then. Thank you very much. The next session starts at Moscow time at 1500. So I'll see some of you there and some of you go to the other panel. And then we have a expert session after that. Okay, that's it. And thanks again and for the technical assistance as well and the translation. Right. Okay. Bye for now.